do, can I hand over to the wonderful Wendy Burns, who probably needs no introduction, but just go to her Wikipedia page if you do want it, because it gives a lot of misinformation. But she's wonderful and has done such fabulous work for those with mental illness. Wendy, over to you.
Thank you, Claire. Yeah, don't look at the Wikipedia page. I was just telling Claire it's full of errors and I've got to sort it. If I could have my slides, please. Thank you.
No, I don't need confirmation. It's fine, thanks.
Oh, somebody's even. Could everyone else put themselves on mute? Thank you. Okay, next slide, please. So just a tiny bit about me. Oh, go back one, it's gone. That's it. A tiny bit about me. As Claire said, I was president of the Royal College of Psychiatrists. I now work 2 days a week as an old age psychiatrist in Leeds, and 2 days as the National Mental Health Clinical Advisor for Health Education England. And the reason I'm speaking today is that I chair the clinical group of Equally Well. Somebody's not on mute and we're getting some noise. Can everybody put themselves on mute? Lots of noise. Are you hearing it, Emma? Yeah. Oh, it stopped.
I am. I'm just going through and muting anyone that's not muted themselves, right, but there's quite a few participants.
Emma, can you not do a mute all, please? Carry on, Wendy.
Right, next slide, please. So, Equally Well, most of you, I think, will be. It's a collaboration with a growing membership, and it's set up to improve the physical health of people living with severe mental illness. Next slide, please. It's hosted by the Centre for Mental Health, and it works together with Rethink Mental Illness. And it's co-produced with an expert by experience group and a clinical group, which I chair. And although when I was president of the college, we were very keen on co-production, I don't think I really understood what co-production was until I came to Equally Well. And it really is properly co-produced throughout by experts by experience and by clinical experts. Next slide, please. I'm going to give you the definition of severe mental illness, or one of them, talk about excess physical illness and mortality in people with SMI, and talk about what we can do to change this. Next slide, please. So the definition, you'll come across a number of different definitions, and you'll also, sometimes people use the word serious mental illness rather than severe mental illness, but severe is the one that we usually use, and it refers to people with psychological problems that are often so debilitating that their ability to engage in functional and occupational activities is severely impaired. And the illnesses that are usually included in this are schizophrenia, bipolar affective disorder, and other psychoses. Next slide, please. And the mortality gap. We know that people living with SMI die 10 to 20 years earlier than the general population. And unfortunately, the gap is widening. The rest of the population is getting healthier. I mean, actually, these figures came from about a year ago. So with COVID, this may be changing, but the rest of the population was getting healthier, but SMI patients were not getting healthier at the same rate. So the gap between them is widening. And the premature deaths of people with SMI have gone up by 20% in the last 5 years. There are also people diagnosed with personality disorders, people with eating disorders, and people with addictions. There's also, they share the same mortality gap, but they're not included in the usual definition of SMI. Next slide, please. And diseases that cause this premature mortality, well, if you have SMI, you're 6 times more likely to die prematurely from liver and respiratory diseases. You're twice as likely to die from cancer. You're 4 times as likely to die from cardiovascular disease. And these 4 conditions between them account for over half of the causes of death. And then, of course, COVID-19, if you've got SMI, you're also more likely to die from COVID-19. Next slide, please. Lost years by diagnosis. I'm not going to read all these numbers out, but just look at them. And those are real people who are losing real years of their life due to their mental illness and the physical changes that go with that. Next slide, please. What makes ill health more common in SMI? Well, like everything, it's complicated. There are social and structural inequalities, lifestyle factors. If you've got SMI, it's harder to exercise. It's more difficult to manage your weight. We're more likely to smoke, are more likely to use alcohol. There's the side effects of medication. The medication that we use is very effective, but it does have side effects that damage people's physical health. And then all the stigma and discrimination that still go with mental illness. Next slide, please. Bit about antipsychotics. So many people with SMI take antipsychotic medication. Bit difficult to unpick, but Dolly, who I think is here on this webinar, has done some really interesting work on this. And the mortality in individuals with SMI seems to be highest, either where there's a lack of antipsychotics or an excess of them. So either when you're taking too many or when you're not taking any at all. But when compared to a general population, people with SMI who use antipsychotics are more likely to die prematurely. The mortality seems to be reduced when continuous long-term antipsychotic use is maintained, probably because then people stay well, they don't relapse, they have healthier lifestyles, and the people who are taking antipsychotics are more likely to be engaged with health services. Next slide, please. And a reminder about antipsychotics and metabolism. Abnormalities in glucose regulation were reported in patients with schizophrenia and bipolar actually before there were any antipsychotics. So although we know the drugs have a role, it isn't just the drugs. The illnesses themselves seem to affect how you metabolize your glucose. But there's no doubt that antipsychotics increase the risk of weight gain, increase the risk of impaired glucose metabolism and diabetes, and they increase the risk of metabolic syndrome. Next slide, please. Quick bit of revision here, metabolic syndrome. It's central obesity accompanied by any two of the following four factors: raised triglycerides, and that includes if you're being treated for it, reduced high density lipoprotein cholesterol, raised blood pressure or treatment of hypertension, and raised fasting plasma glucose. And we know that people with metabolic syndrome are more likely to have heart disease and are more likely to have strokes. Next slide, please. Weight gain and medication. The antipsychotics do vary in how likely they are to cause weight gain. So olanzapine and clozapine are more likely to cause weight gain. Aripiprazole and lurasidone are least likely to cause weight gain. Interestingly, there's been a big shortage of aripiprazole recently. So we were certainly told not to start people on it in our trust because there's such a shortage of it. Hopefully it will reappear. Antidepressants and mood stabilizers can also cause weight gain. Mirtazapine is the antidepressant most likely to cause it. I work with the elderly and I quite often see people who've been started on mirtazapine actually to help them gain weight if they're very thin and very frail. And valproate and lithium used in bipolar can both lead to weight gain. Next slide, please. Bit about cancer. Adults with SMI are twice as likely as adults without it to die prematurely, and that's defined as under 75 from cancer. It's thought to be due to differences in every way along the pathway in prevention, diagnosis and experience. And people with SMI who get a cancer diagnosis are more likely to die from it. Next slide, please. And one of the problems with cancer screening, so people with SMI are less likely to access cancer screening. Breast screening, 18% less likely, cervical screening, 20% less likely, bowel screening, 31% less likely. So this shows there's an inequality in the uptake of each of England's national cancer screening programmes. And we're not going to talk in any more detail about that today, but it's an important thing to remember. Next slide, please. So what interventions can we do? How can we change this? Because it can be changed. It's not inevitable that this mortality gap exists. Healthy weight management is one, smoking cessation, encouraging people to actually go for their cancer screening, getting vaccinated for COVID-19 and also for flu, medication reviews and the annual physical health check, which is what we're going to talk about today. Next slide, please. So the annual physical health check comes about, I think, as a result of the NICE guideline. There's a NICE guideline about psychosis and schizophrenia in adults, prevention and management.
Wendy, one more minute.
Oh, haven't I got till 15:15?
10 minutes.
All right, we start early. Okay, so this recommends physical health monitoring of people with psychosis or schizophrenia at least annually. And this has been made much harder by the pandemic and the strain on primary care. Next slide, please. All GPs have an SMI register, and that records patients diagnosed with schizophrenia, depression and bipolar. Over 500,000 patients on this register. Next slide, please. And this is what the annual physical health check includes: weight, blood pressure and pulse, lipid and cholesterol, blood glucose, alcohol consumption and smoking. Next slide, please. So NHS England collects data on this. The last bit of data we have, just under half of people on the registered had actually got their health check. Next slide, please. Also a little bit about where these should be done. It's not always totally clear to services. Next slide, please. In primary care, this should be patients with SMI who are not in contact with secondary mental health services. They've been discharged from them, or patients with SMI who've been in contact with their secondary care for more than 12 months but who have stabilised. Next slide, please. And the people who should have their checks done in secondary care are people who have been under the care of the mental health team for less than 12 months, who aren't stabilised or who are inpatients. Next slide, please. So physical health checks, in summary, a really important way to start reducing mortality in people with SMI, and equally well is working to support these and ensure that they happen in a meaningful way and that they're not just a tick box exercise. Next slide, please. And that's the final one. Thank you for your attention, and I'll be able to take questions later on.
Thank you very much, Wendy. I'm going to now go over to Hannah. Hannah, over to you, and I'll give you a 1 minute warning as well. Over to you, Hannah.
Brilliant, thank you. Can you all hear me?
Yes.
So hi, my name's Hannah Moore. I'm the Vice Chair for the Equally Well UK Expert by Experience group. I'm going to be giving you some feedback on what I've been told about physical health checks for living people in the Expert by Experience group, and a little bit about my personal feedback. I'm firstly going to go over some positives and negatives from what we were told in the group, and then go on to tell you about what some of the carers have had to say in the Expert by Experience group, which I think is really important. There'll be bits that repeat themselves as we've gathered the experiences from different people, but it will just show you the importance of what have been said. These are some of the things that people have said from the Expert by Experience group. So some positives. I'll start with the positives. We discussed my medication levels and agreed to lower the dose slowly. This has massively improved their energy levels and lowered their appetite and made them feel much more positive. The next person said, I had a great experience with supportive members of staff who reassured me, explained everything to me, and discussed what options I had with further support. Also, someone says, as it happens, going from having a great GP for a number of years and then seeing a different one, when they left, my practice was pretty much forgetting about my severe mental illness check, physical health check since the pandemic, asking me to text them my weight and height. I was asked to attend a health check, which I was very skeptical about. I couldn't have been more wrong. There was a new GP on rotation, and as part of their training, and they absolutely nailed it. Proper best practice. Explained why I was there, results of my tests, and when I could access as a result, and took time to see how I was doing, and even rang me back a month later to check on my mental health. Had me booked back in for another appointment and offered numerous referrals or options subject to what I want. Amazing how much just knowing that there's someone to turn to if I need to make a difference. So there's some really positive things about GPs and what they're doing. Here are some of the challenges with GPs and people with severe mental illness experience. So letters in brown envelope, making someone think that they're like bills or bad news. So letters being clear to understand. So some people have said that not knowing why I'm being asked to have a physical health check is a problem. This can cause anxiety, and some people have wondered if it was sending an error and not for them. So also the letter not having an NHS logo on it. So assuming it wasn't the actual doctor's letter and it could be a bill or a benefit letter or something like that that they don't want to open and they're scared to open. Also, the language sometimes was slightly patronising and hard to understand, and they need to be designed they really need to be designed with an expert by experience at hand. Also, not knowing what the physical health check will entail, this caused anxiety about what the check is, and it's good to know the full health check in advance so that they know their rights, make sure that they're not the only ones that have had the full health check and won't be divided up into multiple appointments, especially with those who find it hard to get an appointment. So another challenge is attending the physical health check only to be asked why I'm there, making me feel like a burden. So I know I got to a GP session for my physical health check, and they were like, okay, so what can I do for you? And I'm like, well, you've called me, and I was like, okay, what do I do? I'm here for check. But they're like, oh, okay, well, we'll take your blood pressure and that'll be it. Having the check focused on my weight, which made me want to avoid the place. I left feeling self-conscious and low in mood, not motivated to lose weight at all. I didn't feel that I got any support, and I don't know what else was carried out by the check. Also, people had trouble getting through to the GPs, but everyone knows that the GPs and the receptionists work tirelessly to get hundreds of phone calls a day and put in millions of appointments. I have here a experience of a family member. So they said, my son had a physical health check problem. My son had a physical health problem some years ago, and he has come to expect a yearly checkup. He has never commented or complained about the visits. He usually receives a letter to ask him to attend. It's short and quick to read. It's a standard letter that patients would get. I get the same. Carer says I get the same. Wording is reassuring. I can't remember the actual wording, but you understand it's not an emergency. You're not told what tests you're going to get, which might make some people anxious, especially the first time. And if you've got a phobia about needles and don't know whether you're going to be needing needles. I have to remind my son to make the appointment. I seem to remember in the past he has received several letters to make the appointment as he had not responded. I don't know if his surgery would intervene if he didn't respond at all. I think letters come in white envelopes, possibly with confidential on it. I agree brown envelopes are not a good idea, with people may not open them and mistake them for a bill or a benefit letter. I don't think people are told they could come up with a friend or a family carer. So having someone present may be reassuring for people, and having this in the letter would be really helpful. Regarding weight issues, I don't know how much training GPs have regarding talking about it with patients. I have read and heard somewhere that GPs are uncomfortable talking about it. I don't think the issue of medication is discussed when you have a physical health check, as the GP is not usually involved in the antipsychotics medication, it's usually the psychiatrist. The person would initiate the discussion, and I expect an appointment made with the GP. I feel there's a problem when you're contacted by phone, as you don't know who's calling. It would be easier if you could see on the screen who the call is actually coming from, so the surgery. And actually my surgery do that. It comes up as my surgery when they ring me, so that's really good. So some surgeries do that and some surgeries obviously don't. I know I don't answer calls when I don't recognise the number, so I told my son to do the same. So it's difficult if someone's not, the GP's ringing from a number that they don't know, or ringing from a withheld number. Another feedback from another carer was about the letters being in brown envelopes, making someone think they're bills or bad news. This carer said, my brother hasn't received letters for years. Everything, especially since COVID, is about minimising the amount of interaction and time surgery spends on interactions. We go out into the world on a digital exclusion. We get text messages to carers about appointments, etc., and carers have become social secretaries because the people they care for haven't got a smartphone. There are some barriers for not getting. Here are some of the barriers for not getting a physical health check. So this is from the Expert by Experience group. Not knowing why I've been asked to have a physical health check. This can cause anxiety, and some people have wondered what if it was sent in error and not for them. The letter, not having an NHS logo on it, so assuming that it was an actual doctor's letter. And also the language was difficult and hard to understand, and they need to be designed with an expert's experience in mind. I think what's not included is help for people who don't have a carer, transport, or feel anxious to have someone to accompany them, and what next steps might be after the checkup in the process or journey. All these can be really difficult things to overcome, especially when you have a severe mental illness, and put barriers in the way for people who are actually attending the appointment. We know that the GPs are doing a really good job, and the secretaries in trying to get people to have their check. So it's not always the GP's fault. Sometimes people don't go to their check and they waste the GP's time, not because they're just trying to be awkward, because they're scared, and then that is probably frustrating for the GP. So the medication that people are on often goes unchecked.
Hannah, one more minute. Sorry to interrupt.
No, that's cool. I'm nearly done. The medication that people are on often goes unchecked, such to the stage where I stopped eating completely and had mineral fluids for a long period of time. And I was on medication called lithium. And it wasn't until I went into cardiac arrest for 7 minutes and was rushed to hospital that anything was done about it. My lithium levels should have been checked regularly, but it was left too long. Now I can no longer take this medication because I became toxic, and this medication that really worked for me and didn't encourage weight gain so much. So that's a shame. Majority of people with severe mental illness are on really strong and sometimes dangerous doses of antipsychotics and other medications. And there are more medications to heal what the physical problems those medications have caused. So basically what I'm saying is, if people with a severe mental illness don't get their yearly, or if not more, mental health check, it can be fatal, and that's not me going overboard. I've seen it with my medication and what it's done. So thank you for listening to my presentation. I hope you got some good information out of it, and that was from me and the Expert by Experience group.
Hannah, thank you so much. That was fascinating. If anybody's got a question to ask, can I put it in the box? But I'd like to just, first of all, pick up some of the issues. And yeah, I mean, I think what you've said is so important that we take it for granted that when we send a letter, all letters, that they're clear, but they're not. And actually just getting a letter is frightening, as you've said. I mean, a brown envelope to me means a tax return, which terrifies me. And so what you said is white envelopes, but actually I think you said text messages, because I think nowadays we send text. Is that all right? Did your group feel that that was more appropriate? Because you mentioned about digital literacy, but we don't talk about literacy of letters. But
personally, I think a text would be a really good idea, but I know one of our carers said that they found that they got endless text messages and they were getting annoyed with them and stuff like that. Personally, from my opinion, I think a text message would be really good.
But presumably they would get endless letters. So it's, you know, so what, but I think that was one of the things. The other thing is, listen, we need to include these issues. Are you going to have blood tests? Because I too am needle phobic. And I think if I got a letter saying I was going to go and have a blood test, I'd have to think very carefully about going, but I'd like to know before I went. So, I mean, that's such an important, and the other one you said was about no caller ID. I mean, did I pick you up that you won't pick up a no caller ID?
No, that was one of the carers, and they told their son to not pick up a caller ID. I always pick up my phone. I just in case it's like doctor's surgeries or psychiatrist or
yeah.
work.
But you see, I think it's important because I won't pick up a no caller ID myself for anybody. And even though, so we've got a question about what terminology is best to use. We tend to say review of physical and mental health, but I mean, did your group feel that that was the appropriate terminology, or did you come up with anything? I mean, you've sort of said an annual review, really, haven't you?
Yeah, I think the group found it a little bit difficult for some people said that the terminology in the letter was a bit infuriating and slightly hard to understand, and I think that and then that it didn't include what was going to be done on the physical health check.
And Hannah, you didn't mention the NHS app, which you now should have access, or most people are going to have access to their own clinical records, their own blood results, their own, all the things. Do you think that is going to empower you more to take more leadership in your own health rather than have to be nudged? Or do you think it's just a mixed economy? Some people will, some won't.
I think some people will and some won't, but I think it's a really good initiative personally, because I have the NHS app and I still need to learn how to use it, but I did use it once and it was really helpful. And I think it's a great initiative personally. And I think it could be difficult for people, like especially coming out of secure services and going into the community with who's not been able to have a smartphone for a certain amount of years. And then they're just placed a smartphone in the hand. They're like, oh my God, what do I do with this?
Yeah. But you've taught me an awful lot, and I'd just like to say thank you, because as somebody that has got a bit of influence at my college, I think what you've said is so perfectly simple, which is let's get the language right. Let's use the best way of communicating, no perfect way, but let's use the one. And let's make sure we engage with you, because it works, if only to know that you're still loved and cared for by the system. So thank you very, very much, and hope you get your next journey goes well. So I'm now going to invite Richard to come. Richard, where are you? Oh, there you are. And the next speaker. Over to you.
I think you mean me, Claire. I'm Jonathan.
Oh, sorry, Jonathan. I don't know why I said Richard. Yeah, Jonathan. I've still got Hannah on my screen.
I've got
right,
a case study with a patient called Richard. That's probably what it is.
Probably.
Hi, everyone. Jonathan Bitford. I'm a GP. I share my time between general practice and mental health inpatient settings, where I support the mental health staff to address the physical health of the patient. So today I'm going to connect up perhaps what I practice in inpatient settings with the community. There is unmet physical health need in the community. Slide, please, Hannah. As Wendy said, there's a profound health inequality. Cardiovascular disease prevalence is reducing amongst the wider community, but it's increasing in our patient group who experience severe mental illness. The physical health check, as it's called, but I'm going to sort of question that word a little bit, because it's beyond checking, of course. It's interventions, and I'm going to talk about the interventions. So that screening, that annual review reveals there's a screening for cardiovascular disease risk factors, and on some occasions cardiometabolic disease, hypertension, and diabetes. And it's also, as Wendy said, it's an opportunistic moment to just think about cancer screening where the uptake is lower in our patients, although that's not a commissioned service. I've got 10 minutes, and as a GP, I guess I should be quite familiar with trying to do a lot in 10 minutes, but I'll keep an eye on the time. Next slide, please. So last year's QOF data demonstrated that 40% of patients who experienced severe enduring mental illness did not receive an annual review screen for lipids or for the diabetes screening. 30% didn't have a blood pressure assessment. I'm aware that last year's QOF was not associated with a payment, but it sets out that there is a considerable number of patients who are not receiving the screening that they need to. Next slide. And why is this important? In my GP practice, the prevalence of diabetes is just over 4%. Nationally, it's just over 7%. Published data, diabetes prevalence around diabetes in patients with severe mental illness in Lancet a few years ago was 13%. We did an audit of diabetes care in one of the trusts that I work for, and demonstrated across 11 wards that the prevalence of diabetes was 23%. This is a young cohort of patients, average age in their late 30s. So I am fairly convinced that there is undiagnosed diabetes amongst our community patients. Next slide, please. Case study then. Richard was a patient I saw last year as an inpatient. He did not readily engage or attend with physical health interventions or the annual review. What happens, of course, when a patient is admitted? It's such an opportunity to address that. Unfortunately, this revealed he had untreated hypertension and diabetes. And alongside that, he had the complication of those conditions. He had CKD already, had albuminuria. The objective of this annual review is to prevent cardiovascular disease, and if there's established cardiovascular disease, to prevent its complications. So this is a setback. I think it's rare, and of course the objective is that we have no patients like that. Next slide, please. So I set out with my patients that I'm going to do this in two ways. One is the lifestyle approach that we all support our patients with: smoking, alcohol, physical exercise, their dietary choices. And then with the interventions that prescribers like myself, GPs, our wider colleagues that prescribe, but also those that are here today that perhaps don't prescribe, but so that you know that there is these interventions that we can undertake, that they're effective, and support our patients' understanding and their adherence to them. And they do the same thing. It's all about reducing blood pressure, lipids, glucose, increasing and addressing insulin sensitivity. Think about, if I may say, the mental health prescribing. Occasionally, I'll see a patient who's been on an antipsychotic for a very long period of time, not known to the AMHT. He's maybe travelled, or she's maybe travelled around different practices. I've got a patient I've just referred. He's on 20 milligrams of olanzapine. His diabetes is poorly controlled, and I need to get him onto a GLP-1 agonist. He hasn't had a psychotic episode for at least 10 years, but he, his family, and myself, some apprehension about changing or stopping the antipsychotic. So I'm going to address that with my mental health colleagues alongside the physical health interventions. Next slide, please. I, of course, consult with my patients in an individual way, regardless of conditions that they experience. Sometimes there is, I think, a scope to modify our approach for patients who have severe mental illness. This is a young group of patients. Hopefully we're seeing before they have the onset of disease, but if they do, without the complications. So I must say, a really proactive intervention-based approach to prevent disease and the complications of it. I may be prescribing medications contributing to polypharmacy, but I would set out that this is, in my view, appropriate polypharmacy and why I'm doing it. I'm mindful that a patient comes in, or we speak to a patient, feels absolutely fine. I'm potentially saying that they have a condition or there's a medication that they need to take. But acknowledging that and raising that to awareness. I don't want the patient to have a side effect or something, so they actually feel worse than when they first saw me. I might work around some of our patients' sort of views. If they're not so keen on blood tests, then prescribe a drug that needs less less blood monitoring, for example, a calcium channel blocker. Or do I need to do any monitoring at all? Have a hazard benefits discussion. A person in his or her 30s is incredibly likely to have renal artery stenosis. Do I really need to sort of monitor those UNEs after starting an ACE inhibitor? Think about the thresholds in a very timely way. NICE have published their draft guidance on reducing the threshold from which we consider starting a statin. So this is from a 5% cardiovascular risk for those who are increased cardiovascular risk, and I'd suggest that could include our patients. In fact, I'm doing this already in an inpatient setting of a patient with a cardiovascular risk that is below threshold, but I perhaps some concern about their engagement with community teams afterwards. I might have the conversation now about, say, statin treatment. And then stick to targets. Perhaps with our older population, that I would be somewhat more cautious about lower blood pressure targets for HbA1c, but not in this young population. Stick to your targets and work towards those thresholds. Next slide, please. So interventions, first of all, lipids, atorvastatin 20 milligrams for those with a raised cardiovascular risk, 5% or 10%. We shouldn't be doing really fire and forget. Give the 10 milligrams of atorvastatin and sort of and leave it at that. We need a reduction in HDL, non-HDL of 40%. EMIS lends itself well to this. In the right-hand corner of the screen, you can see the difference between 3 months. I don't use a calculator. We haven't got time. But if it's roughly half, then I'm comfortable with it. I would say that some of our patients who experience like the metabolic syndrome, as Wendy said, or on these some of the medications that we set out, you might not get a reduction of 40%. So you may need to consider an increasing the statin dose. Side effects around statins, I found the Lancet review last year immensely helpful. Sets out that the majority of people who experience muscular pain taking a statin is not caused by the statin. Of course, some people still do, and I'm still going to consider, of course, their perspective on this. But I found this a really helpful framework to support the patient to take the statin. They are central to cardiovascular prevention, but adherence is poor. At 2 years, only 40% of patients are still adhering to their statins. So what could you do? You could use a high-intensity statin like rosuvastatin at a low dose, and don't forget about ezetimibe, a cholesterol binder, 10 milligrams, well tolerated, associated with a 20% reduction in HDL. Next slide, please.
Another minute and a half, Jonathan.
Okay, blood pressure, similarly, underdiagnosed, undertreated. So really my points here would be a blood pressure of 138 over 88 is not within threshold, needs to get it lower. 70% of patients need more than one antihypertensive. Combination antihypertensives work very well because they have different mechanisms of action. I wouldn't increase the amlodipine from 5 to 10 milligrams, combine it with an ARB. Next slide. Diabetes. So the objective is to prevent complications, and that's around education. So refer the patient for structured education. Only about 50% of our patients attend that, but it's the evidence base for its effectiveness is fantastic. And then the triple treatment. So go back and look at the lipids, the blood pressure, and then glycemic glycemic control. Metformin, and if the patient has a raised cardiovascular risk, consider adding the SGLT inhibitor at the same time. And that's about 85% of patients that diagnosed with diabetes have a Q risk of greater than 10%. Next slide, please.
Last minute.
Okay, thank you. And then just again, GLP-1 agonists, again, timely publications by NICE about using the GLP-1 agonists. BMI rates or obesity is higher in this patient group than the wider community, so they should not be left out of this. So consider referring our patients to the Tier 3 specialist obesity services because we can't prescribe them. And so last slide. So in summary, this is a proactive approach in a young patient population to prevent disease, prevent complications, seek targets, keep to them, prescribe if necessary. It's appropriate polypharmacy.
Thank you very much. Can I bring everybody back? And I think we're going to get a new person. But the one question I'd like to ask Jonathan, I've heard talks similar to yours, and it terrifies me because you're not really behaving like a GP. You're behaving like a community physician with an expert in mental illness. And oh, look at Wendy's cat. And I'm terrified that you are expecting, or one is expecting, even, I mean, I've been qualified 40 years. I wouldn't have a clue. You lost me. I mean, fabulous, but you lost me in terms of my expertise on about slide 3. And if we're going to be expecting GPs, a normal generalist GP, to do this, I'm astonished that this is what is being expected. And I have been on a webinar like this before, where I have expressed the same concerns. But isn't there a requirement now for psychiatry to have its own generalist physicians attached to their services who are able to do what you've just done and what you do fabulously? Because we are in the unknown. It's not even that a GP such as himself would know where to seek help or how to seek help or what the evidence. So I suppose I want to ask you that, Jonathan, because it really concerns me that even if we've got 30 minutes or an hour to do it, it's beyond me. It's like me asking to do cardiothoracic surgery in my consulting room because it feels like it's a good idea for GPs to do that, because you're not a GP, you're a consultant physician specialising in mental health. Any thoughts while we wait for other questions to come in?
I completely agree, Claire. I started this work thinking, well, of course, I'm familiar with diabetes and hypertension, but actually I had so much to learn, and there was so much unmet clinical need that I've had to sort of learn from others and read through all the guidance on how to do this. And time, you know, if I've got the time in these settings, I can achieve it, because I've just given you're quite right, I've didactically just given you a lot of information, but central to this is just giving that information to the patients, my patients, and sharing it with them over a period of time to support them with that decision making. And I agree, it's beyond standard. It's way beyond standard general practice.
Can I ask Wendy, because this isn't general practice, and whilst Hannah, I can do your physical health check and ask you the questions and take the blood test, that's where 98% of GPs' knowledge ends, and we don't have Jonathans spread around the country. And isn't there time, Wendy, for psychiatrists either to develop these generalist skills so they do it, or for psychiatry services to have within their services a generalist consultant physician able to do that, and not expect us to do it because we're only going to fail?
Yeah, I mean, that would be brilliant, but a lot of these patients sit outside psychiatric services. So, you know, there's 500,000 people on the SMI register in England. And most of them are sitting outside psychiatric services. It comes from the whole thing of, you know, you remember the time when psychiatrists never discharged anyone. I never discharged anyone for like the first 10 years of my career. I think it was much better then. But anyway, we do discharge people, still overwhelmed by demand, just like GPs. I guess
if they sit outside, isn't that the role of the Royal College of Psychiatry, to actually lobby for them not to sit outside? I'm not saying they should sit inside your service, but these are powerful medicines which we can't even pronounce, let alone know. And you prescribe them. I mean, I don't think any GP would initiate these prescriptions. So they don't
get discharged. Yeah, people get discharged to GPs on these really complicated regimes.
Isn't it something to leave the GP responsible? No wonder Hannah and her group. We cannot do this, and so we can pretend that GPs can do it on a enhanced payment, but we can't. So how can you change this, Wendy? And then I'm going to go to you, Hannah, because I know you have to leave very shortly, to help us with this, because we cannot do this. Wendy, over to you.
Well, yeah, I suppose we need to. We've been concentrating on trying to get the health checks done. So that's, you know, still less than half people are actually getting the health checks, but maybe we need to look a bit more and talk to other GPs as well. I mean, Jonathan's the only GP on our clinical group, so maybe we need to do a bit of talking to other GPs, and actually, you know, maybe your college could help us with that.
College's lead for mental health. I am trained in psychiatry. I've had 45 years, but I don't know how to manage these medicines. So I'm probably as advanced as you can possibly get, because I'm not a physician. I haven't got physicianly training. It's physicianly training you need, not mental health training or psychopharmacology. And I'm just worried that this is being put into the lap of GPs. I take your point that 500,000 patients are outside the service, but maybe we need not just to say, well, then it's the GP's responsibility, but it's everybody's. Hannah, what's your thinking? You're on mute. Yes. Can somebody unmute Hannah? Oh, you're off mute.
Now, I think. Can you hear me?
Yeah.
Personally, I don't agree with discharging people with severe mental illness. I think it can come back at any time. They still need to have their psychiatrist look at their medication as well as a GP, like, or just psychiatrists look at their antipsychotics. Because, like you said, GPs aren't, other than Jonathan, of course, aren't trained in antipsychotic medication and things like that as much as a psychiatrist would be. So I think it's at least that even if they're seen once a year by a psychiatrist or 6 monthly by a psychiatrist. I know a girl who's on clozapine who just gets seen every year, every 6 months, has a clozapine bloods, and has ended up in general hospital, and they didn't know what to do there. Because
Thank you.
Clozapine that was making her levels, her body go funny. I don't know how to explain it because I don't know.
No, that's a perfect. But that's about the level of my experience. Is it makes her body go funny, and that's interesting that you don't think patients with serious mental illness should be discharged. I think I quite agree with you. They're never discharged from general practice, but somehow, so we need to make it work. I'm looking at the questions in the chat box. Somebody's saying, please don't use the term lifestyle medicine. Funnily enough, I was on a course yesterday, a webinar on lifestyle medicine, and we had this debate. Actually, I think it is quite a good term to use. I know sometimes it blames the individual, but I don't think we're implying blame. Has anybody got any sense? Hannah, have you got a view? There's a view that we shouldn't use the word lifestyle medicine.
I don't really know a lot about that.
No, okay, well, we'll leave that one. Anybody got any questions in here? Somebody's talking about funding. I'm assuming, Jonathan, can I just ask you, I mean, how did you get into this and who funds you?
Yeah, that's because just to reflect on what you said, the absolutely central to reducing the health inequality is what we do in the community. I work in inpatient settings and forensic mental health settings because those patients cannot access a GP, and that's why I'm there. There is no provision of funding that I've ever been made aware of to specifically support the physical health of people with severe mental illness in the community. And there's you know, and as GPs, these are long consultations that require several of them, alongside all the other work that we're going to do. So it is really difficult to achieve. I've just about managed it in my practice, but even then we don't achieve the percentages. You know, we're still sort of 70-80% despite the work we do in terms of trying to do the physical health review. Yeah, so there isn't. So I think, but I do think a campaign for greater sort of clinical practitioners in the community is central to reducing health inequality.
Yeah, Wendy, I'm going to bring you in. Somebody's mentioned pharmacists, but I just want to repeat, this is community physician. That's what you are. And GPs are not community physicians. We are general practitioners. And I think there is an enormous problem of pushing this into general practice. But Wendy, what's your thought? And have you any thoughts about community pharmacists being able to do that? Are they any more skilled at being able to do?
Community pharmacists are fantastic, and they're a bit of a success story in mental health at the moment. I mean, Dolly could probably say more because she's a leading light, but there are and HE's been running some training for them, and yes, they can do all sorts of things. And they could do most of, well, they could do the physical health checks. Dolly, why don't you say something, because this is you, if you're still there.
Dolly, are you there?
I am here, but I'm in a cafeteria right now.
Oh, that's all right. We've got another little cat floating around.
So I'm a specialist mental health pharmacist. My reference was to not community pharmacist, but specialist mental health pharmacist. So we do have specialist training, and we do postgraduate education on the management of psychiatric medication. And if you manage to find yourself a good mental health pharmacist to work with a GP practice, that would be invaluable. But community pharmacists are working towards the possibility of doing these checks, and in some areas they have been doing pilots as well.
But Dolly, can I ask you a question though? Sorry, you're in it, but why is it work with the GP? Again, I keep going back to this. Why is it not working with the psychiatrist who prescribes?
We do that as well. We do that as well. We sit in the ward rounds and we do advise, and we've now got the other thing that might change the picture significantly is now that NHS England have commissioned specifically for pharmacists to be in the community mental health team settings, and we've never had that before. So that might be a bit of a game changer, where most outpatient clinics haven't had mental health pharmacists, but they are now going to start having them as a matter of course.
Because what if the GP stopped these medications because they felt they were so out of their depth in prescribing it that they didn't want the responsibility? Jonathan, have you any thoughts? Because I wouldn't be able to prescribe this lot of medication if I was expected to monitor. Hannah, you, is your cat going to speak?
Yeah, probably. They'll be meowing and for food in a minute, but no, I fed them. But they still meow for food. But someone put in the chat that if someone's not engaging with their physical health checks when they're on mental health medication, should they be re-referred to mental health trusts? And I think that's very true. I think if you're not engaging in your physical health checks, you should be re-referred to mental health trust, because you're not looking after your health, and that is a form of self-harm, technically.
Yes. That's a lot of sense. We recently used a service, I won't say which hospital, where we could ask very quick questions to a fabulous pharmacist about complex medication. They are now charging for it, which means as we have no budget and general practice, we've got no way of paying for it, which means we've lost that service. It does seem a bit odd that as a GP I cannot now ring up a Dolly, do you have any sense of that? I'm not going to name the trust, but it's something we used to ring all the time to get advice on medication.
I think I'm sorry, I was shaking my head. That's completely ridiculous that you should have to pay for that service. I would say to any of my colleagues across primary and secondary care, please call me or email me if you need any support. That's what I'm here for. I'm paid by my trust to do that, whether that's for my patients or patients of consultants or patients who are in our area. And we have specialist medicines information services across the country. So I would challenge that.
We have challenged it, but the problem about general practice is we don't hold a budget, so it means we then have to refer, but you can't refer a patient to a psychiatry, a community pharmacist, and therefore there is no way except for referring them back to a mental health service, which will take 12 months to get how do I reduce the azithromycin down, etc. Wendy, and then Ruth Penfold, you've got your hand up.
I haven't got my hand up, have I?
No, but Wendy, did you want to say anything about farm?
Yeah, well, I've connected, so I've had GPs email me, and then I can connect them by email to our trust pharmacist, who will then give advice. Okay. So there is a way through. It's all about making a relationship with people, isn't it? Getting to know your local psychiatrist.
Our large trust is charging, so we can still ring up.
That's completely ridiculous.
I won't mention which one it is.
No, our trust doesn't charge. Our pharmacists will give GPs advice, but the GPs can't really refer indirectly. But they email me, I email the pharmacist, connect them, and then they get the advice.
But presumably that we can't rely, I mean, that's because you're such a wonderful person, but we can't have a system where we're emailing confidential information to somebody who may not see it and then pass it. So that's another action point that I think we should be looking at, is to maybe make this easier. Ruth, you've got your hand up.
Wendy sort of said what I was going to say. I think it might depend on individual trusts. I work in the community mental health team. We have really good relationships with the GPs. If they want advice from some about medication, they'll email us, we'll give them advice. If we don't know the answer, we'll copy in our trust pharmacist. There's definitely no charges for it. But we take responsibility into all the serious mental illness, physical health monitoring. Because
you're a pharmacist, are you, Ruth?
I know, I'm a clinical nurse specialist.
Right.
So we do it, then we can review the results. The psychiatrists can look at what needs to happen, and then we just refer on to the GP when it's stuff that we're less likely to know about. So we would ask their advice about statins or metformin, but made sure that we've done the mental health side of it. So I think it is so much about the relationship between the individuals, mental health teams and the GPs.
Well, what I'm hearing increasingly is that this is an area that really needs to be, I mean, hopefully, Wendy, the group that you chair will start to look at how to do this better, because Jonathan is almost unique, I imagine. I have heard of other GPs, this involvement, but he's not a GP, and therefore we need to find a better way to make sure people such as Hannah get the treatment they need. Saying that, Hannah being allowed to be on lithium with no blood testing is appalling. I think that is well within our remit, and we shouldn't have let that happen. But it's something that we need to be taking forward. Any other thoughts or comments? Anybody that wants to put? I'm trying to follow the chat box, but they're not really questions, they're just comments. Amanda.
Yeah, thank you. Sorry, Amanda Gabrielson. I'm Head of Operations at Together for Mental Wellbeing. So I oversee community support services. So we're a specialist mental health charity. So my question, which I popped in chat, is more aligned kind of from a provider perspective. I'm responsible for overseeing newly commissioned services through community transformation in terms of supporting people to increase an uptake of attendance at physical health checks, but also supporting people to get there. Also kind of following up and doing feedback about how we can improve the experience. And the question that I had really to the wider group is, have you seen any of that having a positive impact at the coalface in terms of uptake or supporting you within your roles?
Wendy, do you want to say, have you got any?
I think Emma might be able to, because there's quite a few initiatives, aren't there, Emma?
Yes.
Have you had any that have actually been successful yet, or are they all still?
Yeah, so at the moment, sorry, from our perspective of a provider, I don't know if it's directed to me, but we're doing the pilot around the primary care SMI tobacco cessation project. So that's launched in Norfolk. And we've seen some success there, but also kind of supporting people to get to their physical health checks as well, generally in Norfolk, and we've seen some success there. So I just wondered if that's
yeah. And I think equally well as gathering, because there's a few pilots. I think, Emma, we're gathering the data, aren't we?
Yeah, we've got a number of members that have shared what they're doing, and we've got some that are basically created teams that are dedicated to contacting individuals on how they want to be contacted, whether it's text message or phone calls or letters. And then we've also got others that are working on trying to help support get them to the surgery, because some people have problems getting to the surgery. There's others that will work with whoever their main contact is. So they might have someone in secondary care that they know better. So they'll link that person in for the physical health check. So there's a range of different interventions happening. And we're also keen from Equally Well to hear more. So if anyone's doing anything great, please do let us know.
Thanks, Emma. I think I was also just interested in if it's hadn't seen an improvement for those offering the checks.
Maybe
we're actually evaluating that at the moment, so we'll be able to let you know after October.
Lovely. And I think one of the outcome measures has to also be the opportunity costs of general practice to be able to deliver care, because if it's taking an hour and a half per patient to do a health check, that's 6, 7, 8, 9 patients that can't be seen, that can't. Jonathan, do you want to say anything? And then I'm going to start summing this up.
So as my last, this has been really helpful for me to think as well, actually, and it's a balance between having somebody, I suppose, with a clinician like myself and nursing colleagues and AMHPs, sort of to be in the middle around the physical health that are connected to mental and physical health, but not to do it all, not to separate it out. Really, it's sort of a focus of supporting my mental health practitioners with their own understanding, almost an educational role, because I can't or we can't do it all. Regarding the monitoring, you made a comment about monitoring. I tend to have a light touch with that. You know, we're asked to do ECGs. There's no prospective evidence that makes any difference in terms of cardiac conditions, although we have to do it. What's the central importance is cardiovascular disease and the early diagnosis of cancer. That is what we should focus on when we see our patients.
Fabulous. So I've got a question for Barbara. Sorry, is that Barbara speaking
I
now?
was just going to ask, no, it was Emma. I was just going to say that Jason's on the panel as well, and he put in the chat that he hasn't had a physical health check since 2019. So I just thought I'd highlight that and quickly give him a chance in case he had something.
Jason, did you want to say anything? Then to Barbara, and then I'm going to draw things to an end. Do you want to put your camera on or keep it off? Or not say anything at all? Doesn't matter.
Sorry. No, I was just going to say that. So when I had one, it was really good, obviously. So it felt like you were being kind of looked after and cared for. But I've not had one since 2019. I had a phone conversation in 2020, but I guess during the pandemic, it's kind of slipped by the wayside. And I just wonder if other people are experiencing that as well, if they are have a severe mental illness and need to have a physical health check.
Well, we've heard that 45% haven't, so you're right. I suspect the pandemic has done it. I'd chase up, send in a digital consultation, Jason, if you can, and tell them you haven't had one and ask for one, or go on your NHS app and try and make an appointment. If you can't do all of those, then try and grapple the phone system. Barbara.
I was just going to say, I've looked at some of the data behind the physical health checks, and just trying to encourage our practices to join the dots, really, because the patients are touching the services of the GP. So they might be having their blood pressure done, but for something else. They might have had a conversation about smoking, but for something else. So we looked at them, and a lot of the areas they were hitting targets, but they weren't hitting all the targets for the same person, if that makes.
I know that does. I mean, but to have a blood pressure check because you've had it checked because you're going on the contraceptive pill doesn't matter if it's then not for your SMI. It's still the same BP check. So I don't think we can berate GPs.
No, I was just thinking it's sort of like that. I know, you know, how busy GPs are and everything else, but that MEC is sort of, if they're there, is there anything else we can do to, whilst they're there, to try and...
Whilst they're there, the average patient with serious illness is consulting about 22 times per year. So I think we need to get a grip, Jonathan, why we're not doing this if the average patient with serious chronicity is consulting 22 times a year, and that's the latest pay. Jonathan, do you want to have the last word? Because
just a really quick comment there. Just what Jason said really chimed with me, that he felt better when he felt good having the physical health review. And that connects with what I've experienced. I think that we get it with any of our patients as clinicians, but to really focus on our patients' physical health, I think has really helped me develop good relationships with our patients. And that has allowed me to do more and been central to actually, therefore, address the risk factors. Yeah.
Fabulous. So just to sum up, 3 fabulous talks and then Jason with his really good intervention. I think what we've learned is that we're all in this together, and this is all of our business, which I know Wendy and others believe that. This cannot just be left to the GP as a tick box over to the GP. This involves community pharmacists, hospital pharmacists, physicians, and if we're going to make life better for the patient at the bottom and help them live longer, I think one of the things that you leaders in this has to find a way of is doing this in an integrated way, because if you're initiating these medicines, then it's important those who understand these medicines continue the care. What I think we've also heard is that for the physical health check, actually one of the major part of it is feeling that you belong and cared for, and that's I think what Jason and others have said. It's the physical health check is the bit that's addressing the physical needs, but actually it's understanding of big feeling that somebody's looking after them. So I'd like to thank everybody for attending. This has been a fabulous session, and thank you very much, and thank you to the organisers. Take care.
Thank you, Claire.
Jonathan, can you send me your email?
Yeah.
It's Claire.Gerard at nhs.net. Thanks.